or you're a physical therapist or rheumatologist, neurologist, I think it's worthwhile knowing about this as a possible technique that you can offer to your patients. This is intradiscal biacuplasty, which is a treatment for discogenic low back pain. What I hope to do in the next 15 minutes is talk to you a little bit about the appropriate patient, the person who can potentially benefit from intradiscal biacuplasty. Then I'll talk to you a little bit about the procedural approach, how we carry this out under fluoroscopic guidance. And I'll talk to you about some of the outcome data that we have in support of this procedure as being efficacious. And then I'll just end with a bit on safety. So let's talk about the history of heating or denervating the disc that interventional pain physicians have been doing. And we've been doing this for quite a long time. Initially, we started by placing a traditional radiofrequency cannula into the disc itself, a straight cannula like we might do radiofrequency ablation of the lumbar medial branch or cervical medial branch. But the reason why this didn't work is you can see that we're actually heating the nucleus of the disc, which is not the proper area where we see nerve growth in the presence of a damaged disc. And so this really was not a very effective technique. So we thought then to ourselves, how can we modify this technique in order to help patients further and really target the actual area where we see innervation into the disc in the presence of damage? And so then we moved on to the technique which was called IDET. And what IDET was is, this, again, a straight cannula, but a curved wire that we inserted into the disc and attempted to thread it around to the posterior annulus of the disc. Well, this was great in theory, but what was happening in actuality is that this maneuvering this wire within a disc, and especially within a damaged disc, is very challenging to do. And while it looks nice here on a picture, in actuality, it's very challenging to steer this. So then we thought, well, again, we're targeting the wrong part of the disc. We need to target the posterior annulus. And so the distrode was the next thing that came along, which was, again, very challenging to thread something narrow through the posterior annulus. That's what gave rise to biacuplasty as a treatment. So who are the best patients in order to treat with biacuplasty or offer this treatment? We know that discogenic back pain is not the cause of all back pain, but certainly a majority of or a sizable amount of patients, between a quarter of patients and up to 40% of patients, are suffering with discogenic low back pain. And these are the challenging patients for which, at least at my institution, a lot of the surgeons don't want to just operate on isolated low back pain, or they may have failed physical therapy. So who should we offer this technique to? We should offer this to the patients who have tried and failed more conservative treatments, like the physical therapy and the anti-inflammatory medicines. This is particularly for the patients with axial low back pain. This is not for your patients with radicular pain. The patient should have characteristics of discogenic pain, pain worse with sitting, worse with riding in a bumpy car, patients who have pain when they're sneezing. For patients whom we're offering biacuplasty, we do provocative discography to demonstrate that one disc is reproducing the pain at that level and that control discs, adjacent discs, are not reproducing that pain sensation. We also need preserved disc height, and I'll show you when you look at the technique itself in the next couple slides. It's important that we have some disc height in order to put the cannula into the disc itself. I typically would limit this to single or two-level degenerative disc disease. If you have 4 levels, it's just going to take you a very long time in order to treat those patients, and those patients may be better served with one of our other interventional pain techniques, maybe something like spinal cord stimulation. So what is intradiscal biacuplasty? What exactly are we doing? From both sides, we're placing a 17-gauge cannula into the posterior annulus of the disc. Radiofrequency is a technique, if you're not familiar with it, by delivering heat at the tip of an insulated cannula. And so what we're doing is we're delivering heat at the posterior aspect, or at the distal aspect of this needle tip. So let's talk about the technique in greater detail. First, what we're doing is we're placing the probes itself, and this is a percutaneous technique. We then employ 2 forms of radiofrequency, which I'll talk to you about in a bit more detail. First, we're using bipolar radiofrequency ablation. Then we're using conventional thermal radiofrequency ablation. I'll talk to you about that in a bit more detail when we go over radiofrequency. This is what the procedure looks like. It's a percutaneous procedure. The patients can either receive no sedation or very light sedation. The last one that I recall doing, the patient talked the entire time to my nurse about her dog and various things. So it's not a particularly painful thing for her to go through during the procedure. They're awake and talking to you. Ideally, we place the probes 2.5 to 3 centimeters apart, and when we talk about the radiofrequency itself, I'll talk to you about the reason for that. This is what it looks like. We do this under fluoroscopic imaging. Again, we want the cannula in the mid portion of the disc, about 2.5 to 3 centimeters apart, in order to deliver that energy. When we look in the lateral image, we want it in the posterior third of the disc itself. So what about bipolar radiofrequency? When we think about conventional thermal radiofrequency or monopolar radiofrequency ablation, the heat is being dispersed from the tip of the cannula around the tip of the cannula. When we think of bipolar radiofrequency ablation, we have to have two cannula, with heat being delivered through one and out the other. So we have a plus and a minus. What that results in is, as you can see on the bottom of this image here, is that energy is being delivered directly between these two cannula itself. And this is what we take advantage of in order to focus the energy that we're delivering for biacuplasty on the treatment area and not getting a lot of scatter in other areas. Now let's imagine a situation where we took two monopolar cannula and put them side by side. Again, we wouldn't be achieving what we're achieving with bipolar radiofrequency ablation because we'd just be creating two areas at the tip of the needle itself. So why did I focus there on the fact that you have to have the cannula about 2.5 or 3 centimeters apart? If we have our cannulas very close together, you're getting no efficiency of adding bipolar radiofrequency because the two lesions that it creates at the tip of the cannula are simply overlapping. If we spread it apart a bit, as you can see here in B, we're getting a large area of radiofrequency denervation at the tip of the cannula and also getting a larger cannula size. Now let's say that we spread it a bit further apart. What we're then getting is energy being delivered between one cannula and the other, but we're getting a bit of a dumbbell-shaped lesion, and we can miss the middle portions of any innervation there. And if we spread it too far apart, what we actually get is two monopolar lesions and have really not taken advantage of the technique at all. That's why it's so important to focus on this 2.5 and 3 centimeter distance as the ideal distance there. One of my expert tips is really go in at a 45-degree angle. That seems to be working for most body habituses of patients with low back pain. So again, we use two sets of lesions. The first lesion is the bipolar lesion. That's what you see in the middle of this screen here, the area depicted by red, delivering energy through one cannula and out the other to create this strip of a lesion. Now, we also spend about 3 minutes delivering monopolar radiofrequency at each of the cannulas itself because we want to take advantage of the area of heating that we get around the probes as well. So we want to get between the probes and around there as well. The bipolar takes about 15 minutes, whereas the monopolar is typically a 2.5 to 3 minute lesion at that time. We delivered the bipolar at 45 degrees Celsius and the radiofrequency, thermal radiofrequency for the monopolar lesions at 60. So what about efficacy? Is this a technique that is working for these patients? And it's not working for every single patient, but we are having responder rates in these narrow inclusion criteria of about 55%. And what does that look like? What does success look like to us? We're seeing a decrease in the visual analog scale, the 10-point pain scale, of typically between 2 and 3 points on the 10-point pain scale. And you say, well, that's fairly modest for a procedure that's invasive. That's about what we're seeing with some of the oral medical therapies as well. But what we're really seeing is these patients improve functionally. We see a 50% improvement on the SF-36 and a 64% improvement on the Westry Disability Index, which is carried out to 12 months beyond the treatment. The patients are finding that it's quite helpful, and in sham-controlled studies, we find that the patients who are in the sham arm are not benefiting from just placing the cannula. It's actually the delivery of the heat at that area which is helping them. And so if they happen to get randomized into the sham arm, they are electing to cross over in a vast majority of the time. So what about safety? Now you think to yourself, here you have interventional pain physician who's delivering 60 degrees Celsius heat very close to the spinal cord. This is concerning to us. And so we looked at safety as well. And the way that we did this is we put the radiofrequency cannula just as we would for the procedure itself. And then we also put various thermometers at various areas which are of critical importance. And you can see there's been 3 thermometers placed at the neuroforamen. There's been thermometers placed within the epidural space in order to measure the temperature at which we're actually heating. As you can see on the graph here, within the disc, we're getting above 50 degrees at most of those areas. Within the neuroforamen, we're not consistently crossing 40 degrees Celsius. And when we get very close in the epidural space, we're getting to about 42 or 43 degrees Celsius, but the remainder of the epidural space is not heating significantly above body temperature, demonstrating the safety of this procedure. So in conclusion, who should we consider offering this procedure to? These are really for those patients who have chronic back and leg pain, who failed the more conservative things like the physical therapy, the anti-inflammatory medicines. Really the patients with axial low back pain that don't have a significant amount of leg pain, and the people that have a positive pain response with provocative discography. Again, the important key if you're going to be performing this procedure is to really be mindful of the distance between your probes. The probe placement is a very challenging part of this procedure, and you want to make sure that you're doing that well in order to optimize your lesion size. Again, putting them about 2.5 to 3 centimeters apart. Our responder rates are, again, about 55% of people responding to this treatment. Again, a percutaneous procedure, nothing that closes the door to any other interventions should they not be a responder to this, something that you can have done in your office with the patient going home immediately then after. Observing improvements in pain intensity, but again, very important for us, observing improvements in their function as a result of the treatment. Thank you so much.